Mm. You have the opportunity to join again, right?
You're muted. You know, it's gonna kick us out every 30 minutes.
No, we are done now. It's not going off again.
Oh, okay.
Really?
All right. Like, you know, about the fight in Ghana, because I don't live in Ghana, I will let you take up on that question, and then maybe I can bring in, like, you know, what we are doing to fight cancer in general. Yeah, you know, some of the tests and treatment options and things like that, and then we can jump into the male cancer. So I'm not sure if Eric is back.
Okay. Okay. So Juliet, you can start with what you are doing over there as we wait for Eric to join in.
Okay, so in terms of breast cancer in the United States, it's one of those cancers that is very well known to a lot of people. And over here, we do a lot of screening, like, you know, from the primary care physician's office to going to see, like, you know, a nurse practitioner, to whoever you see for your general health. This is something that is recommended for women 50 and above, and mammogram is the way to go. Unless you have family history or you have any of these genetic mutations, then your screening bracket is different. And then in people of African descent, Black people, we actually recommend that they start screening early, because Black people tend to have the worst breast cancer, and they are more likely to die from breast cancer than our Caucasian counterparts. So early detection, as we all know, saves lives. So that's where we start from. And based on what stage of your breast cancer, what stage you are diagnosed with your breast cancer, will determine how you are managed. So over here, we have what we call multidisciplinary tumor board, in which every breast cancer patient, anybody diagnosed with breast cancer, is presented in this meeting, where we have medical oncologists, radiation oncologists, surgical oncologists, the radiologists, pathologists. Sometimes we may even have some of the social workers and physical therapists all in this meeting. And basically we just discuss about the case and what is best approach to this, to treating the person. So if it's an early disease, most of the time, depending on what receptors you are expressing, will determine whether we take you right away to surgery, which majority of the treatment is surgical resection, or if we need to give you some neoadjuvant treatment, meaning giving you chemotherapy or HER2 targeted therapy before you go to surgery. So the early detection campaign here in the US is very strong. And, you know, we know that the death rate has decreased significantly because women are being more proactive, getting their screening on time, and we are detecting most of these cancers in their early stage instead of the metastatic stage, because once you have metastasized, you're going to die from your disease at some point. It's just a matter of how long it's going to take, and a month of October like this, majority of the hospitals, majority of cancer support communities do a lot of programs to kind of broaden their awareness. Even at my hospital that I work at yesterday, we did something called Coffee for Cure, in which physicians and health practitioners will go to a coffee place, and we sell coffee to raise money to support breast cancer patients. So the awareness here is good. I will let Eric speak to, is Eric back? I know he just called me on
no, he's
WhatsApp.
Not. He's not. If he's not in, if he's not in, the psychologist will start, and then when he joins, he can give his presentation.
I don't know a whole lot of what they're doing in Ghana. Only what Cancer Support Network is trying to do is to really encourage and educate the public about breast cancer, bring the awareness that early detection saves lives. So all our programs are targeted to getting people screened, and also helping people through their, diagnosis, management, basically.
Right. So thank you so much, Juliet. Is Rita here? We can start the discussion on breaking the spiritual and psychological barriers, so that when Eric comes in, he can join and give us his presentation on that. Rita up here. Right. Rita, are you here? Okay, so I'll start by looking at the spiritual and psychological barriers to breast cancer treatment and survival. And my perception is basically from a psychological lens, essentially. Basically, I've done some work over the years, and what I've done is to look at psychological support for women with breast health issues, or women with breast disorders. And one of the very salient points I've recognized is what I call the demonization of breast cancer, essentially. And so women who have had the experience of the disease and are joined to or affiliated to some religious orientation are demonized. And I think that is one of the major hindrances to treatment, because once they think that there's demonization about the disease, then the next reflex action is seeking for religious support. And so I think that is one of the biggest barrier to survival, because most of these women think that, well, if I'm demonized, then some sort of exorcism, should occur, and then I need to be chained in a prayer camp, and by so doing, I get some sort of healing. And if Eric joins in, I'm sure you have a lot of stories to tell about that. And so they find that a lot more women with breast cancer cases report late to the hospitals, because at a point or during the early discovery of the disease, they find themselves in prayer camps and other religious organizations. Then I think that the other issue also has to do with the conceptualization of cancers, which also falls within the domain of demonization. When people feel that if you have a form of cancer, then I mean, you sinned, or there's a root cause of sin somewhere hidden, unconfessed sin, and sometimes this kind of attributions are made towards family lineages, especially when the disease can be traced along family lines. So people tend to think that, well, if you have the disease, then basically your family lineage is bewitched, or there's some form of spirituality, ill spirituality about the family. And so people, the locus of control, like psychologists will argue, is to externalize. And so they have a very typical saying, someone is doing me, you know, there's a lot of externalization. And I feel that this externalization pushes, you know, the women out of seeking the appropriate medical interventions, and they find themselves in religious institutions who, I mean, by following that, you know, that kind of narration, worsen the plight of these women. I also think that one of the issues on the misconceptions on survival is that the women are told, and there's this lay knowledge that if, for instance, if you take your breast out, you will die. I remember in 2016, I encountered a woman, and she said she fellowshipped with one of the mainstream churches. And she told me that one of the members of her church, the elders of her church, had actually warned her that if she had mastectomy, she was going to die. And so I think that that's one of the biggest barrier to survival among these women. And she told me that she wasn't going to take her breast off. And this was a woman who had started chemotherapy and was expected to have surgery after the chemotherapy. And so there's a whole cloud of death sentence around breast cancer. I feel that there's no, you know, positive approach to dealing with the disease. And so the women themselves are clouded in a state of fear and anxiety, and coupled with the financial burden of care, it is one of the major causes of death among these women. I also think that stigma has a lot to do with, you know, the psychological barriers. Self-stigma, social stigma, essentially. So I've come across a lot more women who are blocked on self-stigma, and then in that cloud of confusion, trying to manage social stigma as well, basically. And so I think that when we look at the barriers, the spiritual and psychological barriers, then you would want to deal with the misconceptions on breast cancer, and also look at a reorientation of the breast. I mean, this year's breast cancer, from my campaign, what we did was to target men, and that's what we continue to do. And in focus group discussions, I try to find their views about breast, you know, and it will interest you that it is still centralized on sexuality. You talk about the breast, it is still sexuality. So I actually began a reorientation on the breast. If men can also view the breast as a symbol of life. I mean, a woman is expected to breastfeed for the first 24 months, according to WHO. And so if we could have, you know, a very life-supporting view of the representation of the breast, I think that our fight for women's health advocacy, not just breast cancer, but especially with the reproductive health disorders, would actually make giant strides in that regard, basically. Rita, I don't know if Rita has something to add on. Rita, but Eric just joined in, so it'll be interesting to listen to what he has to say so that we can move on. Eric. Hello, Eric.
Yes, Yvonne.
Yes. So can you come in with your presentation on public health education, and then what's happening with your BC campaign in Ghana?
Okay, thank you very much.
And I'll be happy to have an experiential view from you. I think that most of the conversations are too rigidly skewed around the statistics. So from your statistics and all that, can you give us an experiential view of the situation?
All right, thank you very much. So this year, the theme for the breast cancer month is detect it, treat it, and fight it. Detect it, treat it, and fight it. Now, why this theme? Why did we conclude on this theme? The point here is that in Ghana here, about 70 to 80% of the women present late to hospitals when they detect a lump in their breast. So many reasons are cited, and notable among them either is a helpful behavior or financial challenges. But whatever being the reason, the point here is that they present late. Now, when one is diagnosed or one detects a lump in the breast, the first thing the person does is to probably ignore it because it doesn't come with pain. So they tend to attribute to something, either boil or something else, until the lump keeps on increasing. Then they began to think about what is happening. Now, their first point of call is probably clinic, and that is where also per experience the problem is, because they go to clinic, see a doctor, probably a house officer or a medical officer about breast cancer and breast disease. So what they do is that they probably mistake it to be any inflammation or anything. So they prescribe something to them, they go and take, and then if the problem persists, they still go again. And that's what the difficulty is, because if someone comes and you realize that you don't have knowledge, you refer. Others, they don't refer. Reasons, I don't know. But they try to do their best. Breast cancer, division of the cell, they don't wait. So you realize before the woman comes, it might have been late. So when they come and then further investigation is done, biopsy most especially done, and cancer is detected, and you break the news to them. I mean, we used to break the news in a crude way to the women, and that also contributes to their absconding treatment. Thanks to God, we had Rita on board who, have a nice way of breaking the news for the women to be at peace and come to terms with.
Network.
Hello, Eric. Hello, Eric. Okay. 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 So since we're having some difficulties with Eric, I was thinking that probably Dillys, Dillys is on the line. You can just come in and then share your experiences as well. And then we can quickly jump to the male breast cancer session. Eric, are you back? Okay, Dillys. Hi, Dillys.
Hi.
Thank you for joining in.
Oh, you're welcome.
Can you tell us your age, please?
Yes, Monday I'll be 47.
Wow, congratulations. You look so young. Sweet 16. We'll give you 16 years. Dillys, can you share your experience with us?
Concerning the breast cancer?
Yes.
Yeah, okay. Thank you for the platform. It's not easy. It's not easy because I remember when I told one of my family members, she told me a pastor wanted to see me and put the hand on the breast so that the pastor would pray for me. So I asked her, so without touching the breast, that pastor cannot pray for me. She said, for you don't believe in it. Now I'm saying, Mommy, I'm not ready to listen to that man. I'm ready to listen to my professionals. So if the pastor cannot pray without seeing me or touching the breast, then I'm not going. So some of these family interventions come in, then the pastors, how they perceive the idea that maybe it's a curse, is this psychological? So immediately you get this, emotionally, you are not even sound.
Right.
So the slightest, if you are not careful, you follow the mass.
Right.
Because this person will come. Another person even told me, why don't we go to TB Joshua so that will give me some folder water so that I'll not even do the mastectomy. Then I said, is he a doctor?
Right.
So the external influences, when this come, if you are not fair and firm, you'll be deceived. So it's not easy in Africa here. It's not easy at all. And at times, even people, things that they will say about it. Maybe you've been cursed, you've done something wrong, that is why you are suffering all this. So I think when it happens, you should focus on what you are doing. If you know what you are doing, I think you can concentrate and come out successfully. Yes.
Right. Can you tell us how it began? Did it begin with a lump in the breast?
I didn't observe that. Because I remember I've been doing my normal screening.
Right.
And even I did, I think a month before that, I even went for scan.
Right.
So when I went, she said there's nothing. Right. So I went for, I think that was in September, on September 8th. Right. So in May, then I observed that I'm experiencing some changes in one of the breasts. So I took it to the hospital. So when I went, then they asked me to go and do that mammogram. So after the mammogram, then I took it to the doctor. Then the doctor referred me to Kolebu. Right. That is where it started. So when I went, I was not feeling any pains, no sign. So but I could see it was heavy. It was heavier than the other one. That was the left breast. Right. So they did the biopsy. And as I said last week, they didn't see anything. Second one, nothing. So some of the doctors were even saying I should hold on because they don't see anything. So I did the third one, incision. That one too, we couldn't see anything. So I did the excision. That is where they saw the traces of cancer. Right. Yes. Yeah. So right. I think it wasn't easy, but if you listen to the doctors, and the doctors in surgical, they are very, very good. Right. They will advise you any means they want to help you, they do. All right.
So I'm glad you talk about the non-lump issue, because it's been difficult to help women understand, or I think that the traditional campaign emphasizes on lump, the fact that the woman has to identify a lump, in the breast.
It's not always so.
Yes. So I'm glad your experience is a non-lump theory. Yes. And one of the critical points we are missing here is that some of the lumps are not even palpable. you know.
Oh, okay.
So yes, so I mean, Eric is here. So you would need some mammogram or scan to detect exactly what it is. Yeah, so I'm happy you shared your experience with us. Please don't leave. We'll have some questions for you, so don't leave.
Oh, okay.
Eric, are you back? Eric?
Yes,
Eric, are you
yes,
here?
I'm sorry.
Yes.
Yes,
So,
I'm back.
okay. So can you?
Sorry, I had network challenge. Forgive me. Okay, so I was saying that when they come and well, depending on what they hear outside, whether true or not, and then also reading on the net. But at times I advise them that it's not advisable to read stuffs on the net because it tends to scare them. You know, those stuffs on the net are standard. For if you are even to read stuff on paracetamol, you may not take it. And so when they read and they saw this this side effect, is tend to scare them away. Okay. So as Dillys said, you are to listen to your practitioner,
Okay.
then take what he or she says rather than seeking information from somewhere.
Okay.
And so yes, so that and then when they're able to go through chemo, they go to treatment. But the point is that someone may also come with about 4 centimeter lump, okay, in the breast. After first, second chemo, the lump tends to disappear,
Right.
and they may think that they are okay because the lump has disappeared. They are okay. If you don't take more time to explain things to them, they may abscond and come later in life with
right.
very
So
serious
Eric,
one.
I wanted to find out from you if there are variations between premenopausal and menopausal women, because I think that we I feel, I don't want to say I feel that we are losing the fight for premenopausal women. I think that there are issues, critical issues there, which are not being talked about. Do they come in with different attitudes compared to menopausal women? And if not, what is the way forward? I mean, in a very brief statement.
Okay, so obviously the attitude between these two groups of people wouldn't be the same. Premenopausal women tends to be quite young, and at times they tend to ask why. Probably my mother is alive 60, 70 years, I am 30, 40, why me? Compared to the menopausal women where probably they've advanced in age. So they tend to accept the fact that we're probably is part of old age. So they just accept, their acceptance, their coming to reality are different. The premenopausal women tend to have problem with accepting it, but the menopausal women tend to accept it fast. I don't know if psychological perspective it disagree or agrees with what I'm saying, but I'm talking from experience.
Right. Okay. Okay. Is there anything you'd want to add to that in terms of critical lessons for the premenopausal women as well, or for women?
Okay, so what I want to add is that when it comes like that, I mean, they should just take time and then seek treatment. Sorry, I'm being distracted. Sorry. They should just take time, seek treatment. They but they also tend to respond very well to treatment. The premenopausal women tend to respond very well, probably because their system are strong enough. So when they accept treatment and follow treatment procedures, they get better.
Right. Okay, so lastly, how do we reduce the fear and anxiety? Because I realized that from my screening exercise, I mean, especially premenopausal women come in with a lot of fear and anxiety. From your nursing standpoint, how do we reduce that quickly?
Okay, that is good. That's why at times I commend Dillys and Co, who are ready to, share their experience with such women. Because look at Dilly, if Dilly should tell that I've gone through all this, you wouldn't believe it. But when she comes around and speak to the women, they tend to accept it more. So we encourage the survivors, those who have been helped by God to survive the disease, please come out, share your stories. Let people hear that it's not as scary as they think. Rita is doing fine, Rita is doing well, but when the survivors also comes around, it's psychic sort of the women to even have hope that, okay, indeed, some have gone through and I can also go through as well.
Okay, thank you. Juliet, thank you so much, Eric. Juliet.
I'm here.
Okay, so everyone, I think in 10 minutes, it will go off and then we'll have to join again. And please pardon us for that disruption. But Juliet, can you quickly take us to the male breast cancer section?
Okay, sure. All right. So first, to go through what breast cancer is, we need to know a little bit of anatomy of the breast. And my little girl is in my back, so I will stand.
It's fine.
So what is breast, right? Breast is a specialized organ that sits in front of our anterior chest wall.
Juliet, we can't see your face. Won't see your face.
Sorry. So, sorry,
yeah,
I have my little girl on my back.
Yeah, so just cue the laptop a bit. Yeah.
Right. Can you guys
Yeah.
see me now? Okay.
Yeah.
All right. So a little anatomy about the breast, right? What is breast? Breast is a specialized organ that sits in front in the anterior chest wall, and male has it and females have it. You know, it just so happened that females tend to have more of some of the tissues that make up the breast. So breast is made up of 4 different cell types, which is the ducts, the lobules, the fibrous tissue, and fat. So in females, we have a lot of the ducts and the lobules. The lobules is where the breast milk are made, and the ducts is what carries the breast milk to the nipples. And so females, because the main function of the breast is really to breastfeed kids, females have more than the males. But that doesn't mean that the males do not have some of these cells. They do have some of these cells. And so because you still have some of the breast tissues, you can have breast cancer. So what is cancer? Cancer is basically an abnormal growth or uncontrolled growth of cells in any of the organs. So in this case, we are talking about the breast. So uncontrolled growth. So breast cancer is uncontrolled growth in the breast, and it can affect any of the cell types that I've talked about, which is the stroma is made up of the fat and the fibrous tissue, or the ducts or the lobules. So if you have breast cancer in the ducts, it's called invasive ductal carcinoma. If it's in the lobules, it's called invasive lobular cancer. It can be in the fat, it can be in the stroma. So males, because they still have some of these breast cells, they can have some of these cancers. And so, like, you know, the myth that males cannot have breast cancer is a no-no, you know, and I know it's a question that had come up our last week program, that somebody had asked, like, you know, does males have breasts at all? Yes, males do have breasts, and that's the anatomy that I have given you. So it's not as common as in females, but males can have breast cancer. I think the lifetime risk is about 1 in 1,000 men can have breast cancer. male breast cancers tend to be less aggressive than female breast cancer. And there are so many different types of breast cancers. When you go to the female part, there are a lot more different types than when you come into male, their male counterpart. So male breast cancers tends to be estrogen receptor positive, which is usually low grade disease. But if it's not caught early and it's not treated on time, it can spread and cause metastatic disease that eventually the person can die from. Males with family history or with a history of BRCA, which is a mutation that can be found in some of these genes, are more prone to having breast cancer, but their risk of prostate cancer is higher than breast cancer. So most men that have breast cancer over here in the US, we would test them for a mutation, whether they are mutation carriers or not, because breast cancer should not be happening frequently in males. In terms of treatment, the treatment tend to be similar depending on the biology of the tumor that you have. So let me just take you guys through some of the subtype of breast cancer. And like I said, in males, we tend to see a lot more of the estrogen receptor breast cancers, so which is usually after your surgery, we just put you on hormone therapy, or if there are lymph nodes involved, then you may require radiation therapy. But there are some rare forms that are more common in females than in males, such as HER2 positive breast cancer, which is the protein that some of these breast cancers express. And there are targeted therapy that needs chemotherapy, like in combination of chemotherapy to treat these cancers. So sometimes, depending on the size of the breast mass, or whether there's a lymph node positivity, at the time of diagnosis, we may recommend that they go through some form of chemotherapy with a HER2 targeted therapy, for a couple of months before they go to surgery. And especially the fact that in males, they don't have a lot of tissue like females, that you can consider lumpectomy, basically just taking the lump out. So some of them may need to go through chemotherapy or HER2 target therapy to shrink the disease before they go for surgery. What else? So the treatment, like I said, depending on the stage, and we stage each breast cancer based on the tumor size, the nodes involved, how many nodes are involved, and whether they have spread beyond the lymph nodes in the axilla, which is your armpits, or not. And that will kind of determine whether we add radiation to surgical resection or we add chemotherapy. But with male breast cancer, estrogen receptor positive, usually you can put patients on either tamoxifen. Tamoxifen is the one that has been studied the most. Nowadays, aromatase inhibitors are coming out, but in males, typically we put them on tamoxifen, which is a hormone therapy. It's a pill that you take once a day for up to about 5 years. Yes. You are muted. You are muted. I can't hear you.
Yeah, I wanted to add that I realized there's an upsurge in Ghana of male breast cancer cases, but I didn't hear you talk about lifestyle, and I'm wondering if that is one of the significant, factors we should be looking at in present times.
Okay. So, as you probably know, we've done a lot of studies in female breast cancers, and not a whole lot is known about male breast cancers. But I think whatever applies to the female breast cancer, the risk factors can apply here as well. Like I was saying, most male breast cancers usually have some underlying genetic mutation or significant family risk factor that kind of predispose them to it. But, so we will kind of extrapolate from the studies that have been done for female breast cancers here, because it's the same kind of tissue that are being affected. So exercise has been shown to have a positive effect. Exercise reduces the risk of breast
Nice.
cancer. And I'm part of Cancer Support Network of Ghana, and this month our campaign really focuses on releasing breast cancer facts every day, like, you know, one fact about breast cancer. And one of the ones that I love the most is alcohol intake. You know, taking alcohol in moderation. Drinking too much has been associated with breast cancer risk, and we know that some of our men like to drink a little bit too much, you know. So alcohol intake in moderation. Smoking has been linked with breast cancer as well. And what else? Smoking, exercise, and diet. You know, eating more fruits and vegetables as opposed to red meat is another risk factor. Red meat is a big risk factor as well. So exercise is the big one. 45 minutes, three times a week, I believe, is one of the big ones, actually.